a good number coming in, and we're recruiting, I think, on average around about 40 patients per month. So that's fantastic. Well done, everybody. Much appreciated. And as you probably know, if we go to the next slide, we are updating our sample size. Just to, if you've been on previous webinars, we pointed this out. When we originally powered the trial, we were looking only at 90-day mortality, that dichotomous endpoint, yes or no, whether a patient survived or not. But we deliberately added in then the outcomes over time. So whether patients improve, get out of the ICU, get out of hospital, and get home quicker, and measure that over the 90 days. So that gives us a lot more power. And then we've been able to therefore reduce the sample size down to needing 1,300 in the diagnostic and fluid parts of the trial, and a smaller number in the GM-CSF, that subset, so only 400 patients. So based on those recruitment rates and so on, for the diagnostic and fluid parts of the trial, we project we should finish recruitment in just over a year from now. So 12 and a half months, we think we will should have complete the recruitment. And if we go to the next slide, you can see that recruitment over time. You can see here how it's picked up and stayed fairly constant over the last certainly 6 months. The orange is if we continue exactly as we've been doing for the last 6 months. As we've got a few sites coming on board, the green dotted line is hopefully where we will actually finish recruitment, maybe before the end of August. But our plan is to hopefully follow the orange line. I think we've just done it. Maybe there's a slight dip in July, obviously as summer holidays started. Maybe there are a few patients and teams around to recruit. But hopefully we can make sure we follow at least the orange line and ideally get onto the green line to just give us a month or two leeway. And that will take us up to the 1,300 patients. That has been provisionally agreed with the NIHR, and we're just going through the process now of submitting that variation to contract, and also a substantial amendment with the regulatory bodies. And so that is in preparation, and we'll obviously send out the new protocol once that's all been adopted. But just so you know where we are. So a year to go in the diagnostic and fluid trial. If you go to the next slide, we can then look at the GM-CSF recruitment. Again, slightly more varied, just fewer numbers. We are just over 150 patients, it may be 152, I think, possibly right now. And we've got more sites coming on, and also we were thinking we may be able to, the more sites might, who initially said they weren't going to open to GM-CSF, might open. So sort of our orange line is as expected, green is optimistic, and the blue dotted line is very optimistic. As you see, it's only one patient per month different in the whole trial. So there's real scope to come in earlier, but you'll notice all of the end dates are obviously more than 12 months away. And so what we're planning to do in the spring of next year is undertake a futility analysis. If it turns out that it's clearly going to be futile, that we're not going to be able to see any benefit from the drug, we would stop recruiting in the trial. But if we get through the futility analysis, i.e. there is still the potential for benefit, we would need to ask for a further extension to keep the trial going for another year. But we thought everybody, both the funders and you as investigator teams, probably want that reassurance that if we're going to carry on for 2 more years, we should do a futility analysis to decide whether it was worthwhile continuing. So that is our plan, and we should have around about, hopefully, maybe just over 200 patients by the time we do that analysis in the spring of next year. So those were all the points I was going to raise about the study and how it's progressing. And just to say thanks for getting us along this steady recruitment, and obviously anything you can do to get us up to the green or the blue dotted lines, we can obviously deliver the trial more quickly. Happy to take questions at the end, but I'll perhaps hand over to Ravi and team now to go through some of the other points we wanted to update you on.
Thanks, Tony. So the next section is just some recent site queries that we had, and we were hoping that maybe we'd be able to share some experience between site teams. So there have been a few sites who have gotten in touch with us recently about a few patients declining consent to take part in the study, and wanted some advice and guidance on how some of the higher recruiting sites are handling this. So we were just wondering if there were any sites who would like to share their experience or any advice for some of our newer sites on how to approach that initial consent conversation with potential participants.
I'd be interested to know if people think there's any, has anything changed, or is it just bad luck? Obviously some patients and families always say no. Not sure we've noticed any difference locally here. Any thoughts? Those, Sean.
Hi. Um, to be honest, I mean, we've I think we've recruited quite a few, but actually we've had probably at least half of the people decline, either the actual patients or their personal representatives in their family. I don't think there's anything differently we've really done. And it's pretty much been pot luck, frankly. Um, I think the major thing is just trying to get to the family to the patient or the families quite early in their journey, and it gives them a bit more time to digest and actually to speak and have time to think about it. A big problem is often that the families will want to digest information, go home, and then call us back. And often, sometimes, then there's been a delay that they've actually often agreed to the study after the 24-hour window. But in reality, I don't think there's really much we've done differently.
Okay. And Sean, which site are you on?
Stoke Mandeville.
All right. Okay. Yeah, you've had a few recently I've seen come through, so
Yeah,
well done.
yeah, thank you.
Uh, yeah, it's tricky, obviously. That just patients, and obviously their family, if it's a legal representative, that's obviously their right. I just wonder, it's tricky giving them enough information because, again, I do feel this sometimes with people we approach that, particularly if it's the patient, if they're feeling overwhelmed, which is quite clear when they're acutely unwell, it feels overwhelming. So again, if there's the way of just sharing the minimal information with them, and even try to balance that with, again, not to push people to take part. But I mean, I think there isn't a whole element where these treatments are likely to benefit earlier. This is the whole point of the diagnostic test, is to get results earlier. And if we wait to send it off, it is slightly a bizarre situation where we have to get permission to send off the diagnostic test. But that is the way. But I just think, again, hopefully the approach we try and take is that this is sort of part of our usual business in our ICU, recruiting patients to these studies, evaluating new treatments. So it's not, obviously they need to know exactly what's involved, but not too big an ordeal for them. Um, any other thoughts, comments from anybody? about processes? Always good to hear about things that have worked if you've struggled and found a good way to make things
Hello, this
happen.
is Kim
Yeah.
from Bristol. I don't know if you can hear me. We're having a few problems in our office. Can you hear me okay?
Yep, we can hear you
Oh,
very well.
brilliant.
Hi.
Thank you.
And well done for your great recruitment.
Oh, bless you. Thank you so much. Thank you. I think it just helps sort of trying to portray to the patients and their family that we are part of the team with ITU. We're not just the add-on, and I'm sure I'm speaking to lots of people who already know this, but I just find sometimes it takes a couple of goes going back and forth and building that rapport with the families and the patients so that, sort of tell them a bit about the study, but not too much, and just sort of like small bites, really. And then saying that's part of their care, and also, especially with the diagnostic, it gives us extra information about the patients regarding the bugs, should we say, and then the treatments with the antibiotics. So it's sort of obviously reading the room, but just doing it sometimes in small bits and not giving up, should we say. But obviously they are allowed to say no, as we all know that. But again, it's just sort of building up that relationship with the families and the patients, and obviously trying to catch it. It's much easier if you can catch them face to face before they've gone home. You get a better response, I think, rather than just on the telephone. So that's just the way that I do it, and that's the tip that I can give. That's okay.
Yeah, no, very helpful tip, and it obviously works. I think I haven't actually counted the numbers and made the comparisons, but you may or must be close to being our top recruiting site, I think.
Oh, wow.
We got
I think we're
91.
91. Yeah, we had a break for data collection, but yeah, we're back on it now.
Yeah, so your technique's obviously working. I mean, I think that's sensible. But I do think that, that breaking it down into smaller bits, I mean, again, it's not necessarily even research, just that's how my family communication works. It's often best to do it in small bits over time, because it is
Yeah.
the whole situation can be overwhelming when people are critically ill. So just break it down. Obviously, we have got a limited time frame, as Sean pointed out. We have only maximum of 24 hours. But I think it's not expecting to have the piece of paper signed in one go, come back, let them think about it.
Yes.
And often, again, I found families, they just want a few moments to talk amongst privately, if the family are at the bedside with the patient, just a little bit of hesitancy, talk amongst themselves and kind of like, oh, of course we want to take part. And as you say, it may give better information. It may help continue to improve sepsis care over time. And most people are sort of happy with that. I think, pointing out there isn't a lot of extra follow-up, after hospital. It's minimal, in addition to standard care.
Definitely. Yep.
Ravi, back to you.
Yeah. Thanks, Sean and Kim and Tony, for all your helpful insights. And then I just wanted to check while we've got Tony on the call as well, if anyone had any other queries regarding consent or any queries that have been popping up at your site about the eligibility criteria, or any aspects of the eligibility criteria that you find that you might be struggling with, again, that we might be able to share some guidance with.
No specific queries. Obviously, if there are, let us know. I would just remind people in general, it's supposed to be a pragmatic trial, reflecting what's happened for the majority of patients. So most of the queries about eligibility, I think, start from the basis that they probably are eligible, and is there a very specific reason why they are not? And there will be some, but generally we're trying to record, particularly for the fluid and diagnostic part, all comers essentially with sepsis, but obviously check the exclusion criteria, but maybe don't overthink it. If you think they're eligible, they probably are, would be my starting position.
I'll move on, but if there are any questions, please do raise your hand or pop them in the chat. Oh, yes. Sorry, I've just seen a hand
Yep.
go up
Yeah.
from Dora.
Hello. Hi,
Hi.
it's me. It's Dora from Westmead. Hello, Prof. Gordon.
Hi.
We had a couple of people who were eligible, but the initial presentation was with DKA. I know that it may affect the fluid limb, but if the DKA has been sorted, which is quite easy if you follow the DKA protocol, can they still be eligible if they're in the 24-hour time frame? Or DKA is just their absolute no-no?
So obviously the reason for the DKA exclusion is for around the fluid management. So I think if you've when you say the DKA is resolved, if you've come off a protocolized fluid management for DKA, then you could say the DKA is over.
And the acidosis
would be,
has resolved and all that.
then I think I'm just bringing up the criteria. I don't want to, as I said, we have to respect the exclusion criteria, but I mean, we haven't set a time frame. I think if you say if it's over, it's over. But I'd just be careful though, because in my experience, DK often is not properly over, and they may still have fluid requirements. And then what we don't want to do is randomize a patient who say is on a restrictive fluid, or the conservative fluid, I should say, and deresuscitation. And then people say, well, I'm not happy to implement that because of their DKA they had earlier. Then they shouldn't be included. But if you say, oh no, they had some ketones in their urine, and we're not managing them according to a DKA protocol, that's fine. It's nothing specific. It was just purely so that they could follow the fluid protocol. And of course, because you get randomized to both parts, it applies to both the fluid and the diagnostic. The patients have to be similarly eligible.
Okay, thank you.
Any other queries about eligibility criteria? If not, we'll move on to the next part of the webinar. So we just wanted to let you know some upcoming database updates. So we're just in the final stages of getting these implemented. But just to give you all a heads up, some changes that are going to happen. The first one, which I think people will be glad about, that the data visit form is no longer going to be a separate CRF form, but it will be incorporated now into the daily data form. And also there are some options now to say if any of the fluid input or output is unavailable. So if the patient's been discharged to the ward and you're unable to obtain the fluid charts, then you can select this option. And just to note, all of these changes are applying for new participants only. It won't be applied retrospectively to all of the previous patients. Some more changes. So we will be adding the following lab results for patients randomized to the GM-CSF intervention only. So these questions will just appear on the daily data form for the days where they're receiving IMP treatment.
I mean, obviously, everybody will notice that although it looks like a number of new questions, of course, these are all just the counts that come out on your differential on your full blood count. So it's not that much extra information, but just some of the sites have investigators have asked around how the GM-CSF might change the different white cell counts and understanding response to therapy. We think it's useful to catch the differential here. So hopefully that's not a lot of extra work that is just on the full blood count result.
Thanks, Tony. And also there are options to select not done if any of those results were not done for that day. So some other changes, we're going to have an option to say if the telephone questionnaire was not done, and just 2 reasons why. So if it fell outside of the follow-up window, or if you were unable to contact the patient. And then on the randomization assignment form, previously it said treatment and then the treatment allocation underneath, but this was causing some confusion during randomization. So the wording will now change to randomization allocation. And then I'll just hand over to Paulina to discuss queries on Open Clinica.
Thanks, Ravi. So something that has come up over the past couple monitoring visits is replying to queries. So we've noticed that when some users log into Open Clinica itself, they can only see queries that have been assigned to them specifically. As monitors, when we assign queries, we assign it to no one in particular at the site, just so all data entry users at the site can answer these queries. So if this is an issue that comes up when you log into Open Clinica, there's a very easy way to sort this out. So what you would do is you would just access your queries tab like you normally do on Open Clinica by clicking on the top right-hand corner of the database. And then in the top row, you have all your different columns, and you would just make sure that under assigned user, this field is left empty. So it doesn't say your specific username, it's just left clear. So you could just on the very right-hand side, you can just clear all filters, and then that should then populate all queries which are open at your site. And then another question that has popped up is when you are replying to queries, whether you should assign this to a specific monitor or whether you should just leave this empty. So that's completely up to you. As the SepTiC study team regularly reviews all queries for all sites. So we'll pick up any queries that have been assigned to other monitors or that have been left empty. So as you can see here on the bottom, you could either assign this to a monitor or leave this empty. It's completely up to you, and we will pick that up. And now passing on to Promi.
Thanks, Paulina. Just a quick update on the Florence system, which handles the electronic investigator site file. So for sites using the electronic investigator site file on Florence, just a gentle reminder to please ensure it is kept up to date in the same way you would keep a paper ISF up to date. So this includes all study documents and relevant correspondences that should be filed in Florence alongside the copies of the wet ink signed documents. So this includes the consent forms, the eligibility forms, the EQ5D5L telephone questionnaires inside the source documents e-binder. Next slide, please. Thank you. And also a reminder for next month that the SepTiC team will be attending the UKCCRF, which is to be held on Monday the 7th to Tuesday the 8th of September in Brighton. And the SepTiC trial team will be hosting a lunchtime session from 1:15 to 1:45 on Monday the 7th of September. The room is to be confirmed, and hopefully we are looking forward to seeing a lot of our trial locations over there. I can see there's a hand raised up. If you want to ask a question.
Hi, yes, sorry, it's just a question about the previous slide.
Yep.
So we have 2 very large ISFs for SepTiC at the moment, the paper ones. So I was just wondering, should we continue with the paper, or do we need to use the Florence, or do we need to scan all the documents we have in our paper site files and put them on Florence? Because it feels like there's going to be some stuff in our paper one and then some stuff in Florence. It just, yeah, so what should we do? Because we do have 2 very large ISF paper files.
Can I just double check that currently your trial locations are maintaining a paper site file, is that correct?
Yeah, we have
Okay.
two large files.
Yep, so we will get in touch with your trial location on migrating to the electronic investigator site file. And we will let you know how to go about transferring all the documents from the paper site file to the electronic one. So it'll be part of the process, but we will get in touch with
Okay.
you for the next steps. Hopefully that's okay.
Okay, yep. Thank you very much. Thanks.
No worries. Any other questions on Florence or the UKCCRF? No. Okie doke, no worries. The next slide, please. Thank you. And just a reminder that our next webinar will be held on Wednesday, the 7th of October from 2 to 3 p.m. Are there any queries or any best practices? We can open the floor to any questions that anyone may have. So feel free to unmute yourself, put your hand up, or pop a comment in the chat below, and we can always read it out.
I'm going to ask the investigators a question for those who are already using Florence for any feedback around it. We're keen to use it. We found we think it's helpful and reduces paperwork and keeping things up to date. I know the NHR is always looking for efficiencies, and some R&D offices are really enthusiastic about it. Others are less so. It seems to make sense to me that we go electronic. And so particularly those sites who are using it, I welcome any thoughts, comments. How's it gone? So Estefania, very simple and easy to use. All right, okay, good. Kim, you
Oh, hiya. We do use it. We use it for Romeo, a study.
yep.
And it is all right. Yeah, it's. I feel like if it's very simply worded, it's easy. You know, like if you have point one protocol, point two, you know, in the sub, what would I call it? Like subfolders. If everything is worded really simply and all the documents are worded very simply, then you can just add things on folders and there's no big deal. But if it's like, oh, subsection 3.11, oh, subsection 4.12, and like if everything is in really strange subsections, it makes it really, really difficult. And then we have to go back to the team and be like, hey, where do I need to file this document? Because you have so many different folders, there's so many different subsections, and it just gets very, very confusing. But if Florence is very simple, then I guess it would be easy if it would be simple.
Okay, so it's make sure the structure is simple and easy
Exactly.
to navigate, I'm guessing. Yeah,
Because
okay.
I feel like if you don't have an admin and there's a lot of nurses, I don't think they have a lot of time to go through Florence and every single subsection and read it and be like, oh my God, where is this document going now? I think it's just, it can take quite a bit of time if it's not
Okay.
simple. Just saying, because Romeo 1 is not simple. And there's like too many training logs. There's study training log, and then there's another training log, and then there's another thing, and it's just yeah.
Okay.
But that's just me dealing with it.
Useful to hear. We know the Romeo team. They're not directly our team, but we know them. We can chat with them as well. And see, I saw about training. There is training. Like everything, you have to do training before you can use it.
Yeah, the training is provided centrally by Florence. So it's by role and it's like a mixture of videos with subtitles to watch through. But we provide you with all the links that you need.
Sorry, me again. I did
Yeah.
send our certificates that
Yeah.
we've done the Florence training. So yeah, so we've done it. We're familiar with it. So
Perfect.
yeah.
Thanks, Linda. Yeah. If you have the Florence training already completed for another trial, we're happy to accept those. Any other questions or queries about Florence or anything else? Is anyone attending the UKCCRS? Oh,
Go.
yeah, we've got a hand up. Is that the Belfast team?
Hi, Ravi, it's Lindsay and Christine from the Royal site.
Hello.
Hi.
Hello. We had just a wee query in terms of the SepTiC consent. We have been following the process of if there's a next of kin available, calling them and using the telephone consent. It does say in the protocol about going to professional legal. I suppose my query, our visiting isn't until 3 o'clock in the afternoon, and sometimes, you know, sort of waiting until that person is visiting can sort of delay consent. But at the same time, it feels slightly unsavoury to go professional legal whenever you do have an on-site next of kin that will be available just at a slightly later time. I suppose I was just wondering, are you happy that we continue with the telephone consents if they're available? Or do you really want us to go to the professional legal sort of within the 2 hour window or the 2 hour time frame?
Yeah, we're happy for you to use the telephone agreement for the patients next of kin if they're not able to come into the hospital, you know, due to the visiting hours. Then yeah, please do use the telephone agreement, and then when they come to site, then you can give them the full patient PIS.
Yeah, I would second that. I absolutely agree. We we really want to get patients in and treated early. And I think we know in all other aspects of sepsis care, providing the care promptly leads to the better outcomes. And I worry if we delay too long, we may not get the benefit of either diagnostics test or even the fluid therapies if it's set. So there's a real priority to get them in. I think therefore using if you know you can speak to the family over the phone, we should do that electronic consent. But just to reiterate, I think the professional legal representative is there for that reason to get patients in early, and it seems. And you know, it is proved by the ethics committee, and every you know, to delay treatment is, I think, is unethical as well. So you know, just to help people get that in, their thought processes. This is not around ignoring consent for coming into the trial. It's about getting patients treated, and we should follow the pathway, which I think telephone makes the most sense. But just say we've got these other processes rather than delay. I think we should try and get people in as early as possible. John, did you have any other comment on that?
Yeah, we've had a lot of discussion around this because we're really trying to, I suppose it's a balance, isn't it, between, I think on the one hand, not approaching families when the option is there doesn't quite feel right.
No, I agree. With family, if you can speak to family, you should speak to family. I think that's the way I do it. But I think that can be
Yeah.
telephone.
Yeah. I guess equally, so presenting a family with a done deal when the option was there to consultant doesn't seem right. At the same time, putting them under tons of pressure to say, we need you to make a decision in the next 10 minutes, really isn't great either. And we sort of struggle with this a little bit in the trade-off. So I mean, I don't think there's a single answer to this. I think it's very much let's take each case as it comes and see what the time looks like.
So it's interesting.
Yeah.
I mean, just going back to the clinical stuff, we just had a conversation last week. It was around our visiting hours, and we said we thought we would had two open are visiting. Our starts at 11 o'clock, and I was thinking, I thought we started quite late. But here you only start at 3 o'clock in the afternoon.
We're
But
very
again,
yeah.
this is where I struggle. How can delaying treatment until family come in be the right thing to do? And
Mm.
certainly when I've included patients with a sort of under the emergency waiver, he sort of said to them, look, we started because they were sick and they're unwell, and we felt we should get on and treat them. But now we're coming to you. If you don't want to continue, we will fine. We will stop. And it's only been a few hours. Nothing much has happened. And I never had a family say to me they thought we did the wrong thing. I've had a few who've said, no, I really would rather my relative was not part of the study. Please take them out. But I understand exactly what you did, and why you did things rapidly. And I think most families there'll always be an exception, but the overwhelming majority of families, I think, appreciated that you were being prompt and responsive in your treatment. You've come to us and explained the processes, and now they've got the option. They've still got the option to come out. Slightly different, maybe for the GM-CSF aspect, but you can that there is often that's a bit later anyway. But you can always wait for that if you felt that was they were coming in, and then have that conversation with them then. Although again, if they're eligible, they're probably returning their immune system back to normal. If they're immunosuppressed, is probably the earlier you do it, the better as well. Once they met those criteria. So,
Yep.
And I think just if anybody's thinking of anything else, go back to the point that I think was Kim made earlier around this is usual care. This is we're trying to get research embedded into what we do clinically, so it's not this special add-on that requires this can only happen. We can only do a PCR diagnostic test once the family have come and visited. This is part of what we're doing, and we're evaluating these in our hospital. We put them in so we could get the test done. But if you don't want to be part of it, we'll come out, just so you know, this is all sort of part of the routine.
Mm.
There are no other questions we could. Oh, we just got another. Certainly.
Well, so the variation to contract is going through. There's no extra money other than extra money needed to keep the study going, if you know what I mean. It's the same the same money to support the trial is going on, but they haven't said, oh yes, increase your per patient fee or anything, if that's what you're meaning, May. And the budget has not been approved by the Department of Health. So it's been approved at an NHR level. But these things, for those who know how NHR works, it has to go to the Department of Health for approval. And we're waiting on that. And in fact, they came back and queried some of the monies we were asking for. Making sure we only ask for what is absolutely essential. There's nothing else. Maybe finish it and people have an early lunch.
I think that sounds good.
Or an
Thank
ice
you.
cream.
Thanks very much.
Thanks, everybody.
Thanks, everyone.
Enjoy the rest of the summer. If you haven't been on holiday yet, enjoy your holidays.
Thank you.
We can end the meeting for.
Yeah. Okay.